Thank you very much. Last year I was here and I came into a hospital that had a dedication to sports medicine and orthopaedics, a fabulous golf course and wonderful gymnasium facilities, and I thought I was in heaven. This year I come, the hospital has 2 extra extensions. My daughter is working on a journal under the supervision of Dr. Popovich, and the journal is going to have an extremely high impact factor. I'm travelling with my wife, and my son-in-law is managing 2 Olympic-sized swimming pools. This time I think I am in heaven. I'm going to try and restrict myself to those workers in this review who have a larger series and those who are still working in sports hernias, because some of the series have only got 6 to 60 patients in them. So we can't really confine ourselves to athletic groin pain proximal to the inguinal ligament because it doesn't take into account chronic groin pain at the inguinal ligament or in the adductor compartment. And if injuries distal to the inguinal ligament are ignored, then we're going to miss out on adductor longus dysfunction and obturator nerve entrapment. And what about osteitis pubis? How does this fit into this limited scope? Is it distal or proximal to the inguinal ligament, or is it a part of the inguinal ligament? So let's go. So for those of you who are not familiar with the concept of the conjoined tendon, this is the conjoined tendon here. It's that insertion along the pubic crest of the internal oblique and the transversus abdominis, and it joins with the rectus abdominis. And when we're talking about incipient hernia, this is what we're talking about. It's a part of the groin disruption injury syndrome. The syndrome consists of a sports hernia, conjoined tendon tear, adductor tendinopathy, obturator nerve entrapment, osteitis pubis, and labral tear of the hip joint. And it's due to chronic overuse, tearing, hemorrhage, inflammation, collagen microfracture, and imperfect repair. And just to remind ourselves, this is one of John Reed's stills of an ultrasound of a sports hernia. This is the right side, this is the left side. The right side has the bulge. And this is what the bulge looks like at surgery. This is one of our own pictures. This is a direct hernia, occult hernia, sports hernia. This is medial, this is lateral, this is superior, this is inferior, and this is what a sports hernia looks like at surgery. Now this is a very important slide because it just summarises the surgical options for sports hernia. So the operation can be open or laparoscopic. The open can be sutured by a plication or a darn, and we've heard about the Scholdice repair from our 2 French colleagues this morning. And it can also be minimal, which is the Moschovec technique. It can be a reconstruction, which is the technique I practice, and it can be done with mesh. The mesh can be Liechtenstein, or there's a bilaminar type of mesh that can also be used. The laparoscopic repair always uses mesh. It can be a transabdominal pre-peritoneal repair or a totally extraperitoneal repair, both of which require staples, coils, or glue to fix in place. Biological mesh is being used, and I'll say a few words about that. Resorbable mesh is also being used, and then in between those comes this condition here of inguinal tenotomy or Lloyd's release, which is quite different to all these other types of laparoscopic repair. And don't forget, in our series there's a 12% incidence of labral tear which require hip arthroscopy and debridement, which we like to have done before the reconstruction operation. And also pelvic instability can occur, and that requires pubic bone stabilisation by an orthopaedic colleague. Last year, the European Hernia Society sent out a questionnaire about surgery. They set out a 16-point multiple choice question and got 120 responses to an online questionnaire about managing of the sportsman's groin. 76% of people had had experience in managing the condition, but only 73% had done more than 10 cases per year. So the majority 73% had done less than 10 cases per year. And the etiological factors were posterior wall weakness, pubic tendinitis, nerve entrapment, and conjoint tendon injury. And in this particular survey of the European Hernia Society, ultrasound was used, MR was used. Rest and analgesia for 6 months was advocated by 82% of the questionnaires. 9.5% performed surgery initially, and the type of surgical repair was a Liechtenstein mesh repair. That's a standard mesh repair. Totally extraperitoneal repair, transabdominal preperitoneal repair, both of these are laparoscopic procedures, or a simple posterior wall repair, which could be a Scholdice or a Dahn. Now, it's important at this point in time to just think and look back at the evidence we have for surgery for sportsman's hernia or athletic pubalgia. And there's only 2 randomized controlled trials. First one was from Ekstrand and Ringborg in 2001. Took 66 soccer players after 13 months of conservative treatment and divided them up into 4 groups. Incipient hernia was diagnosed on herniography, plus or minus a test injection into the area of pain. And the groups were randomized into Bassini repair, which is a rather old-fashioned style of tissue repair, stitching. They had a group of physiotherapy 3 times per week, rest and non-steroidal anti-inflammatory drugs. Had another group of individual strength training exercise and a non-treated control group. And then they followed up at 3-6 months with a visual analogue scale. And crossover was offered to those who were in conservative treatment that did not do well. So the control group, they were unchanged at 6 months. But in the operated group, all had lower pain scores on coughing, sit-up, jogging, kicking and sprinting. And some were offered crossover, all were offered crossover, and 23 of 45 crossed over from the non-surgical group into the surgical group. And all in the surgical group had decreased symptoms of coughing, jogging, sprinting, kicking, and sit-up at 3 to 6 months. And the conclusion from this particular study was that individual training, NSAIDs, physiotherapy had no benefit compared to untreated controls at 6 months. And that surgery significantly, effectively decreased pain, and surgical candidates were cycling, running, training daily 6 to 8 weeks post-operatively. So this is really the first randomized controlled trial that showed that surgery worked for sports hernia or athletic pubalgia. The next study came from Pajanen from Finland in 2011, which was a laparoscopic or an endoscopic study. These workers, they randomized 60 patients after 3 to 6 months of conservative treatment. 31 of these players were national soccer level players, and they had chronic groin pain or a suspected sports hernia. I say suspected, and I'll come back to that. The operation was a TEP, totally extraperitoneal repair, versus 2 months of active physiotherapy. Now 2 months is not very long. It probably could have gone on longer as far as the active physiotherapy group goes. Visual analogue scale was used 12 months after randomisation, and the endpoint was full return to sport. The outcome was that in the operated group, 90% were successful at 3 months, but only 27 in the conservative group. And the technique that was used by Pajanen was polypropylene mesh, and he implanted mesh bilaterally, even for unilateral symptoms. And we heard something about this morning in the discussion. And he had no specific post-operative physical therapy program, which is a bit of a shock. And the outcome, fortunately, the MRI was blinded and found that bone marrow edema disappeared or improved after surgery. Adductor tenotomy was required. It delayed recovery, but at operation, no macroscopic disruption of the posterior inguinal canal wall was seen, which I guess is not surprising because it was an endoscopic approach looking posteriorly. He excluded patients with adductor tendinopathy. He excluded patients with avulsion fracture. He excluded patients with hip joint or bursitis and other exclusions. But we know from our own work that adductor tendinopathy, avulsion fracture, and disorders of the hip and joint all occur as part of the syndrome. So there was a significant number of exclusions that may have skewed the results. The discussion of this paper was very, very interesting. Pagenin believes that the endoscopic mesh supports the disrupted conjoint tendon better than an anterior approach. He believes that the pressure is distributed more evenly after this type of mesh repair. The balloon dissection could possibly assist with neurolysis, that is, freeing up nerves from scar tissue or from chronic inflammation. He believed that the conjoint tendon defect, the inguinal enthesopathy, and the osteitis pubis are all manifestations of the same disease entity, and I agree with that. Bone edema, osteitis pubis, and stress fracture, insertion tendinitis are all diverse symptoms of the same overuse injury, and I agree completely with that. Now, when we're talking about open operations, the first person, of course, to talk about is Gilmore. He described the syndrome. He did his first operation in 1980. And who was looking for definitions? Per was looking for definitions. Here's some definitions from Gilmore. Injury to the external oblique aponeurosis, conjoint tendon pubic tubercle attachment, and dehiscence between the conjoint tendon inguinal ligament causing posterior inguinal wall deficiency. He defined sports hernia as a bulge or an incipient posterior inguinal wall hernia that creates lower abdominal or groin pain, leading to loss of inguinal canal integrity, but without the presence of a true hernia. Now, Gilmore's work is massive. He'd seen 7,500 patients in his 30 years. He retired the year before last. Almost 4,500 patients were operated upon. And the type of sports that he was working with were soccer, rugby union, athletics, racket sports, and he's got this little category here, 10% of no sport, and most of those were injured workers who get the same injury but don't respond as well to treatment as sports people. The type of sports that he was working on: professional soccer, 84% required operations; rugby union, 62% required operations; rugby league, 79%; cricket, 68% required operations; athletics, 39%; field hockey, 58%; racket sports, and so on. And then he didn't see many females. He didn't see many females, some in racket sports, dancing, football, and so on. But interestingly enough here, there are some sports in which he never ever saw a groin injury, and these were boxing, gymnastics, swimming, and cycling. His operation, at operation he saw a tear in the external oblique causing dilatation of the superficial inguinal ring. His aim was to restore normal anatomy to each layer and put the groin back the way it was through a 5 centimetre incision. He repaired the fascia transversalis with ovicral, used a #1 nylon tension-free darn. His team has subsequently changed that to Proline, which is what we use. He closed the external oblique with ovicral, which is a dissolving stitch, and he closed the fascia, and he found that 40% of his patients had adductor tears, and 18% in his series had chronic or severe adductor tendinopathy requiring tenotomy. So 18% adductor tenotomy in his series. And this is what a split in the external oblique looks like. This is medial, this is lateral. This is what the split in the external oblique looks like. And he also describes some shredding of the external oblique. And we see that sometimes at operation also. And this is what a darn looks like. This is one from our series, but this is what a darn looks like. It's a figure of 8 #1 Proline darn from the conjoint tendon region to the reflected part of the inguinal ligament. Now, his results were very successful. 97% success in professional athletes, 4 weeks average return to sport with a range of 3 to 7 weeks. We have never, ever been able to achieve that. And when I asked him, how do you get your players back so early, he described prehabilitation. They start their physiotherapy or their exercise before they have their operation, and he gets his players back in under 7 weeks. He had 3% recurrences and 10% occurrences on the opposite side to the one that was operated upon at 10 years. His work has been very, very controversial, and this slide on controversies and scepticism answers some of the questions. He believes it's a specific injury to the inguinal canal. It's definitely not a true hernia. He believes the pain generator is inflammation. It's not a true hernia, and it's not a pre-hernia. He prefers a reliable repair rather than a minimal, fast repair. He likes a reliable, long-lasting repair. Never uses mesh. He explained the low incidence in females because of the descent of the testicle in the male, and he also described some coexisting pathology, femoroacetabular impingement, which we heard yesterday from Per. He described labral tears. He does see occasionally pubic instability and accepts 2 millimetres of vertical pubic symphysis shift, but an unstable pelvis with midline or perineal pain occurred in 6% of his series, not an insignificant number. He rarely saw obturator nerve entrapment, and occasionally he has repaired in association with pubic bone stabilisation in a group of Welsh footballers. And this stabilisation involved plating across an unstable pubic bone. The next big worker in the area is Mrs. Moschovec, Ulrike Moschovec from Munich. Her work has been mentioned earlier today, and she believes that the abdominal wall is important for slide-bearing movement. She's also described this biomechanical matrix of crossing of tendons and ligaments, which we've seen beautifully illustrated yesterday and also today. She describes a circumscribed weakness in the posterior wall, allowing a bulge, and the bulge is a PPF, a preperitoneal fatty hernia, PPF, preperitoneal fatty hernia, which develops during kicking, causing compromise of nerves and a dull, burning nerve pain. She believes the injury is due to a cranial and medial displacement of the rectus abdominis, causing tension on the pubic bone and causing pain, with radiation to the adductor, the scrotum, the pubic pain, and she believes that low back pain is also part of the groin disruption injury syndrome. She only does 4 to 6 weeks of conservative treatment because she believes that a chronic pain syndrome will develop if it goes on more than 6 weeks before surgery. So the aim is to retain the slide-bearing component of the abdominal wall with a sound tissue repair, quick return, no mesh. She does it through a small cut in the fascia transversalis. She replaces the preperitoneal fatty hernia, and she's never seen a true hernia sac as a cause of sportsman's groin. She resects the genitofemoral nerve. As Jill said this morning, she resects the genitofemoral nerve in about 5 to 10% of cases in a running overlap type of suture, moving the rectus abdominis insertion laterally to secure it, and she does all this under local anaesthetic. Her results: from 2008, Ulrike has taken a prospectively studied group of 134 patients with an average of 90-day preoperative pain, followed up at 4 weeks, 6 months and 5 years, and she's able to achieve jogging very soon after the operation, kicking a ball 6 to 8 days, and 100% back to training by 10 days. I've never, ever been able to achieve anything like that. She hasn't seen a recurrent hernia since 2003 in over 3,000 cases, but if there is any recurrent pain with no bulge, she believes it's due to neuralgia and hopes to get maximum benefit with minimal approach surgery. And this is my take on the Moschovec minimal repair. This is from my own series. This is a single layer repair of the transversus abdominis and the fascia transversalis. We put another layer across that. We don't think that that layer, this is medial, this is lateral, superior, inferior. We don't think that that's strong enough to be a long-standing repair, so we do another layer across the top. Now, the other big worker from the United States is Myers, William Myers from Philadelphia. He describes what's known as an anterior pelvic floor repair. Patients must have pain for 3 months before he will operate, and 138 patients in his series had adductor pain. There's 88% had adductor tendinopathy as well. His follow-up has been excellent, and his success rate is 97% success. And the marker of success is return to previous level of sports performance. And he believes that the injury is a complex of flexion adduction apparatus of the lower abdomen and the hip, and favours a broad surgical reattachment of the infralateral edge of the rectus abdominis to the pubis. His operative description has not been good enough for myself or many other colleagues to follow. So we don't really know what's meant by an anterior pelvic floor repair. His study has been prospective. 45% of his patients have been physically examined 6 months after surgery, and he excluded all cases of classical hernias and those patients whose pain was entirely below the inguinal ligament. And his imaging was with MRI, and 14 patients had an additional tear of the rectus abdominis muscle. We see that as well. 46 patients had non-specific findings, and he used bone scan in 11% of cases and CT scan in 8% of cases. And the outcome at 4 years, 3 patients developed contralateral symptoms by 4 years, that is pain on the opposite side to the side that was operated upon. He's done some redo operations in 12 patients, 4 of whom have had a laparoscopic repair, 4 McVeigh repairs, 2 Liechtenstein and 2 minimals, and he's found other causes in 26 patients. In females, he's only done 1 successful pelvic floor repair, and he believes that the major cause of non-musculoskeletal pain in the female is due to endometriosis. Of the non-athletes, 6 were evaluated and underwent pelvic floor repairs, and these are mostly workers' compensation. He likes the term athletic pubalgia, and his success rate is 97% at 6 months with a 4-year average follow-up. And this is what I think he does. This is the conjoint tendon here. This is inferior, this is superior, this is lateral, and this is medial. This is a split in the conjoint tendon, which we saw so elegantly displayed on ultrasound this morning. This is what it looks like at surgery. It's a split there, and I think what Myers does is that he reinforces this area and calls this the anterior pelvic floor repair. Now, there's been other earlier work, and in particular this is Nesevic's work from Belgrade, and I'm very grateful to Zarko for the translation. I've been looking for Nesevic's work for a long time, and I was fortunate enough to see a translation by Zarko very, very recently. And this is one worker who predated Gilmore. He went back to 1967, 20 years experience, and he calls the syndrome painful symphysis syndrome. 671 football players. What a great number, 671. He did a modified Bassini repair to reinforce the posterior abdominal wall. I'm not sure what modification he made, but that's how it's described. Most patients returned to training after 6 to 8 weeks. He had no recurrences. He had no classical hernias in his group. Other workers who have been involved with open repairs, Messoardi from Belgium, 71 players, average age 24 years, 11 months of symptoms, conservative treatment failures. He did a bilateral Bassini. We're seeing this quite a bit at this meeting, bilateral operations. He did a bilateral Bassini with a concurrent adductor tendon release. Over 4 years, average return to sport was in 4 months. Follow-up, 95% of these players were still active, but he's had some recurrent groin pains causing a halt in the career, and his operative findings are thinning and bulging of the posterior inguinal canal wall. His procedure, the conjoint tendon is attached to the inguinal ligament with a double-layered 2O proline, and bilateral repair with concurrent adductor release, as I mentioned, and he did this in all cases. For diagnostic imaging, he used ultrasound, plain radiography, bone scan, MRI, and he had some non-specific findings: edema, musculotendinous asymmetry, muscle tears, and avulsion fractures. And in our series, 5% of patients with chronic groin pain have avulsion fractures. Now, this is Scott, Mike Scott from Liverpool. A couple of interesting things about his work. He describes Gilmore's groin in the conventional way, but says there are atypical symptoms, and these patients don't do so well. They don't do so well because they've got a labral tear of the hip joint, which can be another feature of the syndrome. This can be usually asymptomatic. The pathogenesis is unclear, but the labral tear is probably secondary to abnormal joint morphology, dysplasia, femoroacetabular impingement, or degenerative changes. And he diagnoses by physical examination and confirms by MR arthrography. Mike Scott from Liverpool. The same worker describes a series of conjoint tendon injuries. Look at this, 1993 to 2009, 1,200 cases of conjoint tendon injuries alone, in professional, semi-professional and social football players, and achieves 99% at 6 weeks in professionals and down to 68% in non-professionals. He has failures, 11% went on to have chronic groin pain, hasn't published this work, it only appeared in an abstract at the New York American Hernia Society meeting earlier this year. Jovanovic from Zagreb, another worker, 99 patients with sports hernia. He performed, I don't know exactly what operation he performed, I can't deduce that from his paper, but he also performed a double neurectomy, and the results were returning to sport at 4 weeks, and 68 patients were satisfied. He saw 24 out of these 99 patients had adductor tendinosis and performed a tenotomy. He saw isolated adductor tendinitis in 5 patients, and he concluded that adductor tendinosis occurs in about 1/3 of all patients with chronic groin pain, which should be treated by tenotomy. And he gave a good balanced overview of the surgical options. And I agree with this. It's about 30%, maybe a little higher, require adductor tendon surgery. Michael Brunt from St. Louis, Missouri, another open repair surgeon. He describes 3 mechanisms of injury: posterior wall defects, ilioinguinal nerve or other peripheral nerve entrapments. He's shown a video at the meeting in San Francisco last year, and he likes a lightweight polypropylene mesh wrapped around the spermatic cord and sutured to the inguinal ligament, and he will resect the ilioinguinal nerve if it's tearing. He anchors the mesh to the rectus sheath, and he's seen more failures with laparoscopic repair, and so he favours this open Liechtenstein mesh repair. And he performs adductor tenotomy because it reduces failures and it increases the blood supply to the pubic bone in his experience. Campanelli from Italy, you'll hear something about him because he's very, very big in the European Hernia Society. He believes that there's the same number of operations as there are for hernia repairs. He's very confused about pathology. He believes that rectus muscle hypertrophy pulls on the tendons of the pubic bone, and the muscles pull against each other, causing compression of the iliohypogastric nerve and can compress the cord. At operation, always the same findings: a bulging of the external oblique aponeurosis, rectus muscle hypertrophy, and iliohypogastric nerve compression. His treatment is to reduce the bulge, release the iliohypogastric or the ilioinguinal nerve, and he uses a lightweight mesh or a biological mesh with fibrin glue. He believes that the muscles are strong and not weak and don't need a strong repair, and has foreshadowed that sports hernia would be a major topic for the World Congress of Hernia in Milan in 2015. And if you're very interested in this topic, you should not miss this opportunity to see all the world's experts in 2015. There is a bilayer mesh device also being used, and this can be implanted under local anaesthetic, and the mesh is inlaid and also an ilioinguinal neurectomy with a 23-month follow-up, 93.5% success at 6 months. But 4 of these patients again went on to chronic groin pain. And this, I think, is a problem of mesh. There will be an incidence of chronic groin pain after implantation of mesh. So I'm going to pause for a moment. That's dealt with the open repairs. I'm just going to pause for a moment, catch my breath and get a drink. and then we'll talk about the laparoscopic or the endoscopic repairs. Anyone like to ask a question while we're just pausing?
I've got the question.
Okay, so we'll move on. So now we've done the open, now we're going to do the laparoscopic. Again, the major worker is Pajanen from Finland. In his 2004 paper, described 41 male athletes of a mean age of 27, 9 months of symptoms, 70% involving the dominant leg, soccer, ice hockey, and these were all failed conservative treatment. He had 4 weeks follow-up and long-term follow-up, averaging 4 years by telephone contact. And the history, pain on palpation at the pubic tubercle with very little other positive imaging or physical signs. He excluded classical indirect inguinal hernias by palpation, so he would have missed some because some of these are occult and can't be felt by the human fingers. And he used laparoscopy to rule out a direct inguinal hernia. The technique is 10 by 15 polypropylene mesh, tacked in place with helical staples, bilateral repair, but again, no specific physical therapy post-operative, which is very, very surprising. And his results, he found no macroscopic abnormality in 24 of his 41 patients. Conjoint tendon was torn in 10 of his 41 patients. There was muscle asymmetry. He describes adductor magnus tenotomy in 2 of his 41 patients. This must be a mistake. I can't imagine anyone doing an adductor magnus tenotomy and expecting the patient to walk again. I'm pretty sure that means adductor longus. And his success at 4 weeks was 95%. Biological mesh is being used by David Edelman in Florida. Single port access since 2010. That is all being done through the one telescope through the umbilicus, single port access. So biological mesh, 120 patients, average age of 37, 93 males, 27 females. The study was retrospective. He followed them up at 4 weeks, up to 6 months post-operatively, and developed a 95% success with a 6% recurrence rate. Now, this biological mesh involves porcine small intestinal mucosa. I can't imagine that too many people would like to have this sort of material implanted in their groins forever. Morales Conde from Seville in Spain, another good worker from the European Hernia Society. He describes 2 types of syndromes. Type 1, the pubic bone stress and degenerative arthropathy, which gets better by rest and anti-inflammatories and retraining. And he describes the sports hernia, which responds to a TEP, totally extraperitoneal repair, to reinforce the weakness, fixed by glue or no fixation of a lightweight mesh. And he's published a little bit. Now this is the unusual one. This is David Lloyd from Leicester. This is the inguinal release procedure. He's the only person in the world who does this as far as I'm aware, and I can't understand how it works. His population is rugby players, often who have had 1 or 2 operations anteriorly that have failed. He likens the tension on the inguinal ligament to tennis elbow, and he finds holes in the inguinal ligament. He finds the lacunar ligament is shriveled. He says the fascia transversalis looks abnormal, and his surgery is that he releases the inguinal ligament from all attachments to the pubic tubercle. That is, he strips off the inguinal ligament from the pubic bone. And he does a limited tenotomy of the pectineus. So he strips off the iliopubic tract and peritoneum and replaces the defect with a transabdominal preperitoneal repair. Using a 12 by 15 mesh, fixes it to Cooper's ligament, and of his results, 85% are happy at 1 month and return to sport, but he has an 8% failure rate, and he hasn't figured out why this operation fails, and most people can't understand why it works. Smedberg from Sweden, been working in the area since 1985, believes that altered biomechanics of the musculoskeleton is responsible for the injury. stronger leg muscles and weaker abdominal muscles, overuse, endurance, excessive agility, uncoordination, loss of rotation, tension across the inguinal ligament, all cause disruption. And he rather focuses a little bit on nerve blocks and does nerve blocks, and if the neuralgia is not able to be blocked by a test injection, he considers that an indication for surgery. Now, he's done two types of surgery. His follow-up is between 3 months and 10 years. He does the shoulder ice repair, which I've heard about from our French colleagues this morning. That's the sutured 6-layer repair. And he also does a TEP, totally extraperitoneal repair. All his patients return to sport, and he believes that the sports hernia is a diagnosis of exclusion. He believes physical therapy can have a role if it's for high quality, but he believes that most patients get better whatever you do to them. I'll mention briefly the obturator nerve, described by Bradshaw, because of the risk of entrapment of the nerve between the fascia between obturator externus and adductor brevis, and it can be tested by EMG, electromyography. And here it is. It's the operation of nerve release is indicated if neuropathy is confirmed clinically and electrophysiologically, and the nerve is released. Here it is sitting on top of adductor brevis, between adductor longus and between pectineus. And you can see how it could get caught up if there is some inflammation around this adductor region. And we do this operation too. Bradshaw, he described 32 cases, all treated by neurolysis, and the presenting symptom was pain down the medial aspect of the thigh. The EMG will diagnose the injury, and compression results from fascial entrapment. This should be tested for every time, and when we did that little workshop last year, as Zarko said, I use a pin to test for sensation, hypersensitivity, if this nerve is being entrapped. And this is what the nerve looks like. It's quite a big nerve. This is one of our own operative photos. This is the nerve as it's been released, and it's quite a substantial nerve. Can be difficult to find, but with practice it can be found and can be released. Now, the best paper comparing open and endoscopic surgery is published by Cordial in 2008. And this is the important line. Results are comparable between open, 93% success, 35% with mesh, and laparoscopic. 93% open, 96% success with laparoscopic. The results are comparable. The criteria was return to pre-injury level of sport. Surgery was effective regardless of what technique was used. However, the recovery time after open surgery was 17 weeks. With laparoscopic surgery, it was 6 weeks. However, in spite of being a faster rehabilitation time, laparoscopic cannot evaluate all the associated lesions because it's done too posteriorly. There's an issue with a laparoscopic repair, and the issue is putting in prosthetic mesh, which can be a contraindication to an endoscopic radical prostatectomy later in life. It's very hard for the urologist to do a prostatectomy, an endoscopic prostatectomy, and achieve a total clearance with this mesh hanging around the prostate area. The laparoscopic method takes longer to learn. You need between 50 and 200 cases, and there are more perioperative complications. And William Myers from Philadelphia, the American expert, he believes that laparoscopic doesn't address the causes of pathology, and it's unlikely to have a long-term successful outcome. Okay, so we're into the home stretch now, and I've been asked to do a couple of specific questions, to address a couple of specific questions, and here they are. First one is the indication for surgery. Physical examination reveals no detectable hernia, but the exact site of pain is identifiable. And this is what Pierre alluded to earlier today or yesterday. Sports hernia can be defined as an injury that can only be confirmed at surgery. So surely our physician colleagues must be skeptical. Surgical repair is indicated in cases of chronic groin pain unresponsive to conservative treatment and with imaging evidence of posterior wall deficiency. The most common surgical finding is a posterior inguinal canal deficiency that creates an occult hernia that's not evident on physical examination. And the period of incapacity with this injury can be very, very long. It can be between 6 months and 5 years, and not unusually can be over 12 months before the injury is operated upon. I've been asked about contraindications, and we don't operate on patients who are getting better on conservative treatment. We try not to operate on patients that have less than 6 months of physiotherapy unless they're under a specialist groin pain physiotherapist. We don't perform a reconstruction on patients with classical hernias because they can just have a normal hernia repair. We exclude urological, gastrointestinal and gynecological causes. And cost is an issue, and patient must have informed consent. They must understand what they're letting themselves in for with the operation. And we don't operate on patients that are on non-steroidal anti-inflammatory drugs or those who are on anticoagulants. Complications after the operation, 10% incidence of urinary retention, and I've never understood why it would be so high, but it usually gets better with a catheter overnight. The bladder fills up with about 700 mils, catheter overnight, drains, take it out the next day. Most patients recover after that. We've had some redo adductor tenotomies. There's a condition known as mesh inguinodinia, which is a chronic post-operative pain, and the reason is probably some reaction to the mesh or some undetermined reason. The mesh can cause ischemic orchitis and testicular atrophy. Bladder injury can occur with the totally extraperitoneal repair, and reproductive symptoms can occur: dysejaculatory syndrome, azoospermia, and infertility if mesh is used. And there's been 17 cases reported worldwide of infertility after a mesh repair. So we don't undertake the surgery lightly. And solving the problem of chronic groin pain must not create other new problems: mesh shrinkage, contraction, migration, inguinodinia, entrapment, ischemic orchitis, dysejaculatory syndrome, and azoospermia. So, getting towards the last couple of slides now. The outcome: successful return to the pre-injury level of sport with no recurrence of injury, even allowing for the high motivation of sport players to train and retain their position in a team. The overall success rate is between 63 and 97% success, and I hope an outcome of this conference will be a randomized controlled trial comparing physiotherapy and surgery. So, in summary, what we want is an accurate assessment. We want to identify those patients with non-surgical pain, where we look elsewhere for the cause in those patients. Consider the groin disruption injury as a syndrome. All these bits hang together: occult hernia or sports hernia, conjoint tendon tear, adductor tendinopathy, peripheral nerve entrapment, osteitis pubis, and labral tear of the hip joint. Hernia, standard hernia repair will not help these sufferers. They need a full reconstruction. We need the help of a groin pain specialist physiotherapist, and we must acknowledge the magnitude of this problem. Thank you.